Everybody, get started here shortly. Just going to wait for some more people to get here. Okay, I think we'll go ahead and get started here. Thank you all so much for joining us. Welcome to the Sonosite Behind the Scan webinar entitled Behind the Stethoscope, POCUS Guided Triage and Management in Pediatric Respiratory Failure. Today, our guest speaker is Dr. Michael Littner Rivera from Indiana University, Riley Hospital for Children. My name is Chris Pennell, and I'll be hosting today's webinar. Before we begin, let me just go over some important information about this webinar. The information in this webinar is provided for general educational purposes as a supplement to professional experience, education, and training, and should not be considered the exclusive source for this type of information. At all times, it is the professional responsibility of the practitioner to exercise independent clinical judgment in each particular situation. Fujifilm Sonosite assumes no responsibility or liability for any misuse of this webinar. During the webinar, all attendees are muted, and we will be conducting a Q&A session at the end of the presentation, so feel free to send your questions in while the presentation is going, and we'll be sure to get to them at the Q&A session at the end. If you're on the Zoom stream, you can type your questions into the Q&A box into the toolbar located at the bottom or the side of your screen. And for our viewers on YouTube and LinkedIn, you can enter your questions in the chat box and we'll get to those. This webinar will be recorded and archived for future reference on our webinars page and on the Sonosite Institute. To get started, let me introduce Dr. Michael. Dr. Michael Littner Rivera has completed his combined internal medicine pediatrics residency at the University of Illinois College of Medicine in Peoria. He then pursued a pediatric critical care medicine fellowship at Phoenix Children's Hospital. With a strong commitment to global health and innovative practice, he completed an additional year of training with a critical care ultrasound fellowship at Western University in London, Ontario, combined with a pediatric critical care global health fellowship in Malawi. During his time in Malawi, he conducted influential ultrasound-based research on acute kidney injury and pediatric cerebral malaria. Currently practicing at IU and Riley Children's Hospital, Dr. Michael continues his involvement in global health research, collaborating on pediatric severe malaria projects in Uganda. His primary clinical and research interests are centered on the intersection of global health and the utilization of POCUS in the management of critically ill children, particularly in lower resource settings. And with that, I'll turn it over to Dr. Michael to get started.
Hello, my name is Michael Littner Rivera, and I'm a pediatric intensivist at Indiana University Riley Hospital for Children in Indianapolis. I want to spend some time talking about a tool that we underutilize in pediatrics, and certainly one of my favorite POCUS applications, and that is lung ultrasound. This talk is for novice ultrasound users, but would certainly be a good review for, I think, any of us that even have some experience. I know that in pediatrics, we are just starting to adapt this tool. So we will be discussing the why of using lung ultrasound, or perhaps some of the benefits of lung ultrasonography in pediatrics, as well as how to perform lung ultrasound and describe what the images are representing or how to interpret those images. Moving on to why of lung ultrasound. First, I think lung ultrasound is an extension of our physical exam. We're trying to visualize the pathology that is affecting our patients. Secondly, it is very doable. Lung ultrasound can be intimidating at first, especially since it's not anatomically accurate. And you will see what I mean by that. But basically, we will be using artifacts created by the machine to interpret the images. Most of the time, we won't be seeing an actual lung per se. And if we do, this is likely pathologic. Next, it is cost efficient and timely. Especially in the PICU, there are many times where we need answers expedited and we don't have time to wait for an order to be placed or for the X-ray tech to come to do the exam. Additionally, it is repeatable. I can repeat the study as often and as frequent as I want or as time allows. And certainly helpful when we're trying to determine if our interventions have led to change in our patients. It is also non-ionizing, which I know chest x-rays have very little radiation, but over time it can add up. And finally, this is a clinician's tool. The gentleman pictured here is Dr. Daniel Lichtenstein. He's a French intensivist who is responsible for deciphering what the lung artifacts mean and is truly the father of lung ultrasound and critical care ultrasound for that matter. According to him, he would steal, or perhaps maybe borrow is a better word, the ultrasound machines from the radiology department and scan his patients at night until he was finally able to crack the code of lung ultrasonography. He has written extensively on lung ultrasound, and I would highly recommend picking up either his book or reading some of the manuscripts that he has published. So we'll move on to a brief literature review on lung ultrasound with a mixture of both adult and pediatric literature. And I just want to highlight the date on these articles. I can't believe it is that 1995 was actually 30 years ago, but that is how long the use of lung ultrasound has been around. As you can see, we are decades behind our adult colleagues. And these are some sentinel publications by Dr. Lichtenstein showing the utility of lung ultrasound to evaluate diseases such as pneumothorax, pneumonia, and pleural effusions, and I would highly recommend them. In pediatrics, here's a meta-analysis from 2015 demonstrating the accuracy of lung ultrasound for diagnosing pneumonia in children. This meta-analysis included 5 studies in all and found lung ultrasound had an overall sensitivity and specificity for diagnosing pneumonia of 96 and 93% respectively, as we can see here. And this is another study in neonates. And although the study had a small number of patients, lung ultrasound had a very high sensitivity and specificity for diagnosing pneumonia in neonates. For those that are in the outpatient world, there's some literature using lung ultrasound in outpatients with a pretty high sensitivity and specificity for diagnosing pneumonia as well. This is a more recent meta-analysis from 2024, which showed lung ultrasound to have a better sensitivity and specificity than chest X-ray for diagnosing pneumonia in children. And finally, I wanted to highlight this article that was published in 2022 about the utility of pediatric POCUS in the management of critically ill children. Now, it's a single center study, and they had 155 patients over 15 months. And during that time, the team found that their POCUS studies changed management in 42% of the time that they scanned. And in particular, lung ultrasound changed management in over 50% of cases. And this webinar is going to be on the Sonocyte Institute website, so you can review, go back and find these studies. You'll have time to look them up and review them on your own. So now moving on to the how. How will I do or perform the actual lung ultrasound? To begin, what probe will we use? And this is a common question that is asked frequently. And the short answer is whatever you have available. If you have options, my preference is to use a phased array probe. I believe it is probably just more versatile than some of the other probes, especially in critically ill patients where sometimes you want to move between scanning the heart and lungs in an expedited fashion and don't want to switch probes, which can be a bit time consuming. And this is the probe that I learned in during my ultrasound fellowship. So this is my preference. Um, I also use the phased array in the abdominal um, setting. There are different software features and filters in the lung preset compared to the abdominal preset. And in my opinion, the abdominal preset just allows better visualization when we're looking at some of the deeper pathology that we will see soon. But overall, the differences between these probes is going to be the type that they use different frequencies. And higher or lower frequency may not mean much for a clinician. Just know that higher frequencies, such as the linear probe, don't penetrate as deep, but have higher or better resolution for some more superficial structures. So for using the linear probe, one of the pros is that it has a better resolution. The cons is that it'll miss deeper pathology, such as consolidations. And for the linear probe, I would use a setting exam. And I would use the lung setting. And I would use this if I had a smaller patient, such as neonates, or when I really wanted to highlight a more superficial structure, such as the pleura. You can also use a curvilinear probe. And for those of us that do global health or work in resource limited areas, you will find that many times this may be the only probe available. Yet you can gain or sorry, you can obtain very good images with a curvilinear probe. Similar to the phased array, you can utilize the curvilinear probe for additional studies and is the probe commonly used for the FAST or the focused assessment with sonography and trauma, or the EFAST, which is looking for free fluid in the abdominal, pleural, or pericardial spaces. It'll be limited by its large footprint, and may miss some more superficial structures. Moving on, the lung ultrasound exam can be done in varying positions, and in the emergency department or outpatient setting, scanning the child in caregiver's arms is certainly an option. In my setting, which is the pediatric ICU, our patients are going to be mostly supine, and that is how we will review the exam done. We will focus on these regions, which are going to be the mid clavicular line, the anterior axillary line, the posterior axillary line, and an additional mid axillary line. And we will have the indicator of our probe always pointed to the patient's head. And so the scanning will be done in a longitudinal fashion. We will try to have the probe as perpendicular to our pleura surface as possible. And as you can see here, sometimes being perpendicular to the chest wall does not necessarily mean you are completely perpendicular to the pleura. And some gentle rocking or angling of your probe will bring out the areas of interest. We will focus on 4 lung zones, which again is how I learned lung ultrasound and is my preferred method. There are multiple lung ultrasound protocols out there in the literature, and particularly in the ICU, scanning some more posterior lung fields can be challenging when our patients are supine and critically ill. Nevertheless, scanning these lung zones, these 4 lung zones, should be suffice to uncover pathology. If you are able and you want to include more posterior lung zones in your practice, that is certainly reasonable and feasible. And without a doubt, including more lung zones will make your scanning a bit more accurate. We will focus on these 5 sonographic features or signatures, if you will. There are certainly more than this, and I would recommend Dr. Lichtenstein's book, Lung Ultrasound in the Critically Ill, for those interested in learning more. But these 5 features will allow us to identify the vast majority of pathology causing respiratory distress in our patients. Starting with the first zone, or R1, L1, depending if we're on the right or left hemithorax. Our reference points will be the mid-clavicular line at the second and third intercostal space. As a reference, we can see where approximately we will be placing our probe compared to this cross-sectional CT scan. We should, from this view, we should visualize the pleural line, which is this bright or hyperechoic line seen here, along with the acoustic shadows of the ribs that border our area of interest. And just for reference, the patient's head is towards screen left, and the patient's feet will be towards screen right. So this would be the superior rib, and this would be the inferior rib. And again, we are scanning longitudinally. We should see pleural sliding, which I hope you can see here as a shimmering or movement of the pleural line. Additionally, we should see other bright horizontal lines deeper within our image, which are A lines, and we'll review those shortly. This would be considered a normal lung image. But remember that this only represents this particular lung zone, and you can certainly uncover additional pathology within other regions we scan. So this cartoon is a representation of what we are seeing with our probe. First, we have our subcutaneous tissue, which will be here, followed by the pleura, which again is this hyperechoic line. We will see ribs, or at least their acoustic shadow. And remember that in our younger patients, their ribs may not be fully ossified, and hence we may not see their acoustic shadows, or the acoustic shadows may not be as dark as seen here. And not represented in this cartoon are these, again, these horizontal lines, which are deeper, and these are called the A lines, which we will review shortly. But first, to review the pleural sliding, recall that the pleura is composed of 2 opposing layers, with the visceral pleura adjacent to the lung and the parietal pleura lining the chest wall. We can imagine as the lung inflates and deflates, these surfaces will slide past one another, creating the sliding that we will see on our image. As you can imagine, if there is air or fluid within this space and the pleura are not in contact, then pleural sliding goes away, which becomes an important feature to identify pathology such as pneumothorax, which we will see later. So next we have the A lines, which are simply reverberation artifacts. Recall that ultrasound does not penetrate air. So when the ultrasound beam reach the pleural line, which is a highly reflected surface, they will bounce back towards the probe, creating an image. Some of these beams will bounce back off the probe again and travel back to the pleural line, and again back to the probe. Since these echoes took twice as long to be captured by the probe, the ultrasound machine gets fooled, if you will, and interprets this as there being a structure twice as deep. Again, another ultrasound beam can reflect once more, and another reverberation artifact is created deeper. So recall that this isn't lung per se. I think that is a misinterpretation a lot of times when we're beginning to utilize lung ultrasound. These again are just reverberation artifacts. It represents that there is air beyond the pleural surface, and basically that our lung is well aerated, especially, well, if there's pleural sliding and you have A lines, it means that our lung is well aerated. And again, we see that here. And A lines can actually have hemodynamic data. So an A line pattern or absence of B lines provides hemodynamic information. In an adult study, an A line pattern had strong correlation with a low pulmonary artery occlusion pressure, meaning in the context of volume resuscitation, an A line pattern provides pretty good evidence that our patient will likely tolerate additional fluid resuscitation. This does not mean that they will respond to fluids, but at least at the time of this scan, if you find an A-line pattern, additional fluid is unlikely to harm them. So our second lung zone will be in the anterior axillary line at approximately the 6th or 7th intercostal space, or pretty much at the crux of the axilla. Our reference points for the image we want to bring forth will be the same as in zone 1. We will look for the pleural line highlighted between the acoustic shadows, ensuring we are perpendicular to the pleura in order to bring forth these A lines. Moving on to the third lung zone, we will be at the mid-axillary line at the level of the diaphragm. And we'll use the liver or spleen as an additional reference point, depending on what side of the body we are on. So we should be able to visualize the diaphragm, which is this curvilinear line is moving kind of deeper away from our probe. Caudally or screen right, we will have the liver or spleen if we're on the left side. And above the diaphragm, we should see well aerated lung moving in and out of view. And some have called this the curtain sign, which you can imagine kind of represents a curtain being pulled. In this area above the diaphragm, we would normally, if there's pathology, identify if there's an effusion or consolidation, we would see it above the diaphragm in this region. And this is a still image of the left side. Please note that again, this is not lung per se. This is actually mirror artifact of the spleen appearing though it is above the diaphragm. Most of the time, mirror artifacts will be easy to spot, and as we will see, we can use the spine to help us determine if it is mirror artifact or true pathology. And again, this is zone 3 from the right, what a normal lateral lung would look like. And similarly, this is on the left, so this would be your spleen. Now for the fourth lung zone, we will place the probe in the posterior axillary line, again at the level of the diaphragm. And you can certainly do this in a supine patient. You're just going to try to be as posterior as we can. Usually this means holding the probe almost like a racket in an overhand fashion, and pushing your knuckles into the bed to highlight some of these structures. And this is the area roughly seen here on this axial image where we will be placing the probe. And this is what we will be seeing. It's a more posterior image. And in supine patients, there can be quite a bit of pathology uncovered here, especially for those who are critically ill. It is also known as the PLAPS point, or the posterolateral alveolar pleural syndrome, which is a term coined by Dr. Lichtenstein in his original work. But just remember that is in the posterior axillary line at the level of the diaphragm. So moving on to pathology, we will discuss pneumothorax, pleural effusions, and consolidations utilizing the 5 lung ultrasonographic features, including the 3 that we have yet to discuss. Going back to lung sliding, which, as we mentioned, should be present in a normal lung. Well, what about the absence of lung sliding? As discussed previously, lung sliding indicates that the pleura are intact. And I hope you can see here in this image that lung sliding, that shimmering, is no longer present. Hopefully you could appreciate that. Importantly, note that A lines are still being produced as the ultrasound beams are being reflected off the parietal pleura. But the lack of lung sliding can indicate that the visceral pleura is no longer intact with the parietal pleura, which can indicate pathologies such as pneumothorax. However, absence of lung sliding does not necessarily indicate pneumothorax. As you can imagine, if you are apneic and that lung is not being aerated, or if you have a right mainstem intubation and your left side is not being aerated, you will not see lung sliding. Similarly, in pathologies such as atelectasis or pneumonia, where part of your lung is not being aerated, you may not have lung sliding. Additionally, if you've had pleural pathology in the past, and some of your patients may have chemical pleurodesis, where the pleura have been adhered, then they will no longer be able to slide past each other. And this cartoon is representing basically what a pneumothorax is, highlighting that the pleura will no longer be intact. And again, I hope you see here, these are your ribs, shadows, and this is the pleural line with absent sliding. Another feature we can use on the ultrasound is the M mode, which stands for motion. Once we have our image, we can use the M mode feature, and the M mode cursor will detect any motion along its path and represent it graphically represent the pleural sliding graphically as we've seen here, which creates a distinct M mode image, which has been called the sandy beach sign. And here we can see why the sandy beach image got its name, with the soft tissues representing the water, the pleura, the waves, and then the beach is those structures that are deep to the pleural line. If there is absence of pleural sliding, the beach disappears, and what we see is these continuous horizontal lines, often referred to as the stratosphere sign or barcode. Now, personally, I rarely use this feature. As you can imagine, most of the time in the ICU, if I'm looking for a pneumothorax, it is because there is some clinical deterioration or perhaps even during a code situation, and things can be frantic. At that time, trying to determine if there is a sandy beach or stratosphere sign can be quite difficult, and trying to really determine both, distinguishing these in a stressful situation can be difficult. Um, so in the right clinical context, absence of lung sliding, I would likely call that a pneumothorax and move forward with needle decompression. But that is my practice and certainly based on my clinical setting. And everyone should adapt their findings to their own clinical settings and patient scenarios. However, a sonographic feature that can help rule in a pneumothorax is the lung point. As you can see here, there is part of the pleura that appears to be sliding. And while half of this screen, there is absent pleural sliding. And this represents an area where the probe is at the edge of the pneumothorax, if you will, as hopefully you can pick up here in this axial CT image. You're just at the edge of normal lung and the pneumothorax. Additionally, we can sometimes see what is referred to as a lung pulse, which are these rhythmic pulsations of the pleura and are transmitted from cardiac contraction. This signifies that the visceral and parietal pleura are opposed and again rules out a pneumothorax. So when evaluating for a pneumothorax, these are four sonographic features that we can employ. Lung sliding, which the presence rules out pneumothorax. Lung pulse, again, that presence of lung pulse means that the pleura are opposed and again rules out pneumothorax. A lung point, which is present nearly 100% specific for the presence of pneumothorax, and B lines, which indicate that which arise from the pleural line and indicate that the pleura are opposed and help rule out a pneumothorax. And we will review B lines next. So what are B lines? Sonographically, they're seen as these bright hyperechoic vertical lines originating from the pleura and extending all the way to the bottom of the screen. This is an important feature, that the fact that they have to go all the way to the bottom, as there are sometimes other signatures that just don't make it all the way to the bottom, and this by definition then are not B lines. So I try to help learners remember that B lines are vertical, if you will, is just the mnemonic that I use. Anything more than up to 2 can be normal. 3 or more will be pathologic. Again, they extend to the bottom and they will abolish your A lines. And how do B lines originate is always a common question. They represent fluid in your interlobular septae, which are these thin walls of connective tissue that separate our pulmonary lobules. They run inward from the pleura and can sometimes be seen on CT imaging when they are thickened. So B lines are fluid in the interlobular septae, and the fluid can be due to hydrostatic forces such as pulmonary edema or due to inflammatory infectious causes. Importantly, they can be an early sign of pulmonary edema and can be seen before pulmonary edema is seen on chest X-ray. Importantly, this occurs before alveolar edema is present, and hence you can find B lines before patients develop symptoms. However, once alveolar edema is present, then they can certainly, once alveolar edema is present, the B lines will be more confluent. As you can see, they're not these single solitary bright lines as we saw before. And confluent B lines, especially when they are this thick, can represent alveolar edema, and patients would certainly be symptomatic when you have this degree of B lines. This was a patient that got admitted to our PICU, and she ended up having pulmonary hemosiderosis. Moving on to the detection of consolidation with ultrasound, and these can be partial or subpleural consolidations as seen here. Here we are not seeing the regular pleura nor a normal curtain sign as we would see in this area, in this kind of lateral area of lung imaging. Instead, we see part of the image with this hypoechoic structure, which is a consolidation, followed by what would appear as a normal aerated lung. And this area of separation has been called the shred sign, which represents the line separating the consolidation from the normal or well aerated lung. A translobar consolidation is usually easier to see. Here, the entire lobe is consolidated, and we can also identify a small rim of pleural effusion. There can be, within the consolidation, you can see these bright hyperechoic spots, which are bronchograms, and they can be static. As you can see here, every once in a while, you can find some dynamic bronchograms, which represent fluid within the smaller airways and are quite sensitive for pneumonia. And the last lung signature is the effusion, which is usually hypoechoic. But as we can see here, it is not necessarily anechoic. And in fact, some of these brighter effusions, or sometimes effusions can be seen to have these kind of hyperechoic bubbles in them, if you will, and that raises suspicion for a complex effusion. Additionally, we can see within the effusion, you can certainly pick up septations of an empyema, which seen here in this patient that I got admitted to our unit who had a MRSA pneumonia and went on to require ECMO.
Now, moving on to limitations, I think one of the big ones, particularly in pediatrics, is going to be bronchoconstriction. So patients that are presenting with respiratory distress due to asthma, our lung ultrasound findings aren't going to detect that. So as you can imagine, in bronchoconstriction, an obstructive process, our lungs are going to be hyperinflated. And what we will see with our ultrasound is going to be pleural sliding and A lines. So it would appear as if those lungs are normal, but hopefully that is a disease process that can be detected with physical exam. Another limitation is that ultrasound is certainly user dependent. And so it takes time and practice in order to obtain not only the images that we are hoping for, but learn how to interpret them as well in the clinical context.
And that is all. Thanks for your time. And now we will open it up to some questions. Thanks.
All right, that is our presentation. Thank you so much, Dr. Littner for this awesome presentation. Everybody, it is Q&A time. So if you're on the Zoom stream, you can put your Q&A questions into the Q&A box on the bottom or the side of your screen. And if you are on the LinkedIn page or the YouTube page, you can put your questions in there and we will get to those also. Looks like we already have one in here. Do you use the lung score for your patients? And if so, how does that score help you guide treatment?
I don't particularly use the lung score. I know that there are some manuscripts and publications that utilize lung score. I think there are. I've seen some for ARDS. I've seen others in neonates, and so I have not adapted it to my practice. I think there are some. I've seen an interesting article, or I think it was a webinar that used the lung score for respiratory therapists for them to adapt kind of maybe airway clearance. I thought it was interesting, but I don't necessarily use it. So I think I just use lung ultrasound and adapt my therapies based on the pathology, right? If there is pulmonary edema from hydrostatic reasons, then you diurese. If we're finding consolidations that we were suspicious for, we will treat either as pneumonia or perhaps it can be atelectasis. If there's effusions, and we can decide to drain, but I don't base it really on a score. I base it on the ultrasound findings and the clinical context.
Excellent. All right. Next question is, what would you suggest for someone trying to start an ultrasound program for RTs?
Well, so I think having a champion is for ultrasound program for any in any context. I think that having somebody that will kind of champion your cause and be willing to teach and QA the ultrasounds and the images obtained, I think is probably the most important. I think that finding tools, I shouldn't say, but for example, like that webinar that I mentioned that I forget where I saw it. I wish I could recall. But I believe it was from Australia, that it was respiratory therapists using lung ultrasound to implement different airway clearance. And so it would be, showing that there's a proof of concept out there that RTs can utilize it and that it's beneficial for RTs. And then, like I said, finding a champion within your division that can help, support the cause.
Right. Next question. Is Lifeline using ultrasound on transport for neonates or pediatrics?
But not that I understand. So in our transport services here, I don't believe we have our critical care transport services utilizing ultrasound yet. I think it'd be great, and I think it'd be a valuable tool, particularly for some of those longer transports, but we're not using those.
Next is, one of the limitations for detecting pneumothoraces is appreciating size. How do you clinically use the information you gather from POCUS on your decision-making to place a chest tube?
Yeah, and I think it's clinical context, right? I think that, right, before, let's say, ultrasound was being used to detect pneumothorax, it was all clinical, right? You didn't really want to get an X-ray of a large pneumothorax because it means you were late in decompressing it. So in a clinical situation where you have a dyspneic patient that requires immediate intervention, I think finding absence of lung sliding would likely indicate that you probably need to decompress. Another way to do that as well would be to just slide down your, usually your anterior chest wall, and determining how many rib spaces perhaps that where your lung sliding is absent. Difficult, I think, to truly quantify how large a pneumothorax is. But again, I think in the appropriate clinical context, it would probably indicate that it needs to be drained. Similarly, if you've got a patient who is asymptomatic and you happen to find absent lung sliding, even in the large area, I probably wouldn't put a chest tube there. Instead, I would probably, try to discover other reasons as to why there may be absent lung sliding.
All right, next question is, have you found POCUS helpful in differentiating atelectasis versus developing pneumonia, which is a common CXR interpretation?
Yes, and I think that, I perhaps should have discussed that a bit more in the PowerPoint. Most of the time, and again, I think clinical context is useful. In the ICU, where patients are going to be supine for quite some time, and mechanically ventilated, bilateral consolidations, especially in the absence of fever and things like that, are likely going to be atelectasis. Now, that's not necessarily the case, but again, in a clinical context, if I find a consolidation in a patient who has been supine with no fevers or other inflammatory markers, I probably would not consider it pneumonia. If there is unilateral consolidation, especially if you're having bronchograms or especially dynamic air bronchograms, I would be very suspicious of pneumonia. And then I was also taught that, depending on your consolidation relative to your effusion, so if you have if your consolidation is small relative to a larger pleural effusion, then that is probably more likely compressive atelectasis, whereas a large dense consolidation with relatively smaller effusion, then it is likely that that's a pneumonia. But I think that one of the things that I like to look for are bronchograms, especially dynamic bronchograms. You won't always see those, but I think those are very useful. And then again, your clinical context. Remember that POCUS is biased, right? We're clinicians. We know what the clinical context, the clinical situation is. Usually, I hope we have a question that we're trying to answer with POCUS, and so depending on what we find, it certainly will inform our practice.
Okay, next question. Have you found that lung ultrasound has significantly decreased the use of X-ray, or is it still used as an adjunct in your practice?
I wish it decreases X-rays, but not yet. I think that eventually it will. I think there's pros and maybe cons of each imaging. I certainly think that ultrasound is a better tool for diagnosing pneumonia. I think ultrasound is a better tool to detect pleural effusions, and certainly for pneumothorax as well. I think one of the advantages of X-ray is that it kind of gives you a bigger picture. It kind of has everything together, and so it is nice to kind of see that. But I think that ultrasound certainly has its advantages as well. At this time, I don't think lung ultrasound has been adapted universally by any means, or enough at least to start diminishing the amount of X-rays, but hopefully in the future.
All right. How many scans would you say that you usually need or usually do for like a good clinical snapshot of a patient?
So I use the lung zones. So usually 8 is enough, right? We're doing 4 per hemithorax. And so that usually is enough. Sometimes I'll take, if there's pathology kind of laterally or posteriorly, sometimes I'll take different clips, just because sometimes when you review them on a quality assurance software, sometimes you will detect things that you hadn't seen while you were scanning. So, like things like air bronchograms, sometimes when you look back, you will catch them. But in general, 8 scans, 8 clips is usually enough. And once you have practice with it, it's really a matter of minutes to get them all, to be able to get all lung zones.
All right. Well, looks like we've gotten through all of the questions here. If anybody else has any other questions, you can go ahead and put those in the Q&A box. And in the meantime, what were some of the barriers to adopting lung ultrasound in your practice, if you had any?
I think that common barriers identified, especially by learners, are some of the perhaps lack of people that have been trained in ultrasound, or at least that are comfortable teaching it. I think that having somebody to review your scans is important. Somebody to kind of show you where to place the probe is just as important. And so I think that's a big one, is unfortunately in pediatrics, maybe some of the lack of trained providers or teachers. I think some maybe perhaps lack of knowledge of maybe the utility of it, or kind of where we've gone. Remember 30 years ago, people thought that lung ultrasound was not possible. That I think that the thought is that because air, or the sonographic waves don't penetrate, or better said, they scatter in air, that lung ultrasound was not possible. That people still don't really know how to use it, or how to interpret it. And I think the lack of it being not an anatomically accurate study, or diagnostic tool, and by that I mean that when you're scanning a normal lung, those lines are not a lung. And so I think it causes confusion. Whereas if you put a probe over the heart, everybody can tell that that's a heart. If you put a probe and you see sliding and some lines, that does not look like a lung, and it shouldn't. And thanks to some of the pioneers like Dr. Lichtenstein, we know what those means. But once you start learning what those artifacts mean, then I think it becomes very manageable. But I think another barrier is that initially it seems it's a bit intimidating, because you don't know what you're seeing.
Great. Well, it looks like we don't have any more questions. So, Dr. Michael Linton Rivera, thank you so much for being here and sharing your presentation with us. It was really great. We had some really excellent questions too, which is awesome. It looks like we are done for today. So we really appreciate all of you viewers coming and watching our webinar. Quick reminder, you can watch previous webinars and sign up for upcoming webinars on sonosite.com/behind-the-scan-webinar. And you can go ahead and scan that QR code there on the screen to visit our webinars page. Thank you so much again to Dr. Michael Linton Rivera for coming to speak to us today. And thank you all for joining us, and we'll see you all at the next one.
Thank you.